So welcome everyone to the latest research on metastatic breast cancer with Dr. Tiffany Traina. My name is Christine Benjamin, and I'm the Breast Cancer Program Director here at SHARE. SHARE is celebrating its 40th year as a nonprofit organization that helps people through breast or ovarian cancer, offering the support of those who've been there. SHARE offers many services, including helplines, telephone and in-person support groups, including 9 telephone support sessions each month for those living with metastatic breast cancer, and educational programs. All services are free of charge to participants, and you can always get more information at our website, sharecancersupport.org. Dr. Traina is an associate attending physician on the breast medicine service at Memorial Sloan-Kettering Cancer Center in New York City and serves as the section head of the triple-negative breast cancer clinical research program. She is an assistant professor for the Department of Medicine at Weill Cornell Medicine, New York City. We're so delighted to have Dr. Traina with us today. Dr. Traina, all yours.
Thank you so much. I really appreciate everybody sort of dialing in this afternoon to spend a little bit of time hearing about what was new at the San Antonio Breast Cancer Symposium, which met in December. This is really a conference that has world draw for researchers and clinicians that focus on caring for women with breast cancer. And we hear everything from early basic science research there to phase 3 clinical trials ready to present their results. So in the next few minutes, I tried to highlight data from multiple different subtypes of breast cancer. And although this is really a focus on metastatic breast cancer, I could not resist putting in some really exciting practice-changing trials that presented in December that have implications for clinical practice right now. So I thought it would be worth you hearing about this. It may apply to some of you out there. It may apply to your friends, and really is sort of groundbreaking change in the way we've treated breast cancer. So over the next few minutes, we'll touch a little bit on triple-negative breast cancer with some novel agents that are very exciting in advanced disease. I will spend a little bit of time talking about drug TDM1 in HER2-positive metastatic breast cancer. And then we'll look a little bit at immunotherapy, which is a hot topic across many solid tumors, also within breast cancer. And while some of the early data in immunotherapy was focused on triple-negative breast cancer, what we learned at the San Antonio meeting was that this may have application for ER-positive breast cancer as well. And then, as I said, we'll touch on some trials, ABCSG18 and CREATE-X, which are early-stage trials but have, I think, high relevance. So the first big question that is ongoing in triple-negative breast cancer is the role of platinums. Now, we've had some data over the past year in first-line treatment for metastatic triple-negative breast cancer comparing taxanes to platinums. Platinums are thought to have activity, particularly in triple-negative breast cancer, because of this association with BRCA. Now, the BRCA gene is important in our bodies to help fix the damage that's occurring to our DNA constantly. And if tumors have a deficiency in that repair mechanism, they should be much more vulnerable to DNA damage and therefore die off more easily. So many triple-negative breast cancers, even if not associated with a known hereditary BRCA mutation, are thought to have a BRCA likeness about them and a sensitivity to DNA damaging agents. And that's where platinum drugs have had a resurgence. Although we don't typically use them in hormone-driven or HER2-positive breast cancer, they may have a role in triple-negative breast cancer. There were several small pilot trials in early-stage disease that showed encouraging results. And so about a year ago, there was a big study reported in metastatic triple-negative breast cancer comparing taxane in the first-line setting to carboplatin. That trial was called the TNT study that Andy Tutt presented, and found that for those patients with triple-negative breast cancer without a BRCA mutation, the platinum seemed to be just as good as the taxane. Now, in early stage triple negative breast cancer, there were several trials going on to see if adding a platinum helped add to the usual taxane and anthracycline that women were receiving, with the goal here that we would help to shrink tumors further and ultimately improve survival. The slide I'm showing right now is one of the first trials that reported out last year. This was a big European study adding carboplatin to a backbone of anthracycline and taxane. It was a complicated design, and I'm just showing the arms for the patients with triple negative breast cancer. The pink lines here are doses of carboplatin. The yellow is an anthracycline, not exactly what we use here in the United States, but similar to, say, adriamycin or doxorubicin. And the green marks are paclitaxel, weekly paclitaxel. And when this trial reported out, they found that adding carboplatin caused more tumor shrinkage, as defined as a pathologic complete response, in addition to that anthracycline and taxane. Now, a pathologic complete response means that when a woman went to her surgery after receiving all of these drugs in the pre-op setting, the pathologist looked under the microscope and there was no evidence for invasive cancer in the breast or in the lymph nodes. And that seems like a really good thing and something we would want to have. But remember, one of the main gold standards for using a drug in early stage breast cancer is to see that we've actually cured more women and that we've improved survival. What you would think is if you had better shrinkage, we would have perhaps seen more women having breast conservation as opposed to mastectomy. But that wasn't the case. We didn't see a lowering in mastectomy rates. We just saw better shrinkage. Now, moving on to a similar study conducted here in the United States was the CALGB trial. This is using a backbone chemotherapy that is one of our standards of care, using paclitaxel with dose-dense AC. So this is a very modern conventional therapy. And there was a randomization to women receiving carboplatin or not, or receiving bevacizumab or not. And when this US study reported out, we saw very similar results to the European GeparSixto trial, that if you added carboplatin, there was an increase in pathologic complete response. Right? So the red bars are the carboplatin-containing regimens, and you had complete resolution of disease in breast or breast and axilla when you added the carboplatin. But what really matters is survival, and that is what was reported out at San Antonio. So before we get to that bottom line, I want to just point out that adding carboplatin comes with a lot of side effects. It is harder to do, and this slide is showing the percentage of women able to receive the planned regimen to completion. So what we'd like to see is that these lines of blue go all the way to 100%. But in fact, when you add in carboplatin, it was hard to get there. On the top part of this slide for paclitaxel, you could see that when carboplatin is added, maybe about 60 to 70% of the time, women were able to get all of the planned doses. And that's suboptimal, right? We like to see at least getting 80% of our doses in. So adding carboplatin clearly comes with toxicity, and we want to see, is that really worth it? Well, the GeparSixto reported out survival data at the San Antonio meeting. And what you can see here is that 3 years of follow-up, the addition of carboplatin had a small incremental advantage to disease-free survival. So that means at 3 years, women were alive without recurrence of their breast cancer. And that difference was about, say, a 5%, even a little bit more so than that, a 9% absolute difference in disease-free survival. So that was encouraging from the German study. However, right after that presentation came the data from the US trial, the CALGB study, where the addition of carboplatin did not improve breast cancer-related survival. They define this as event-free survival, but the same concept that at 3 years, women were alive without recurrence of their disease. Here, it actually appeared about, although numerically a 5% difference, there was no statistical significance between these two lines. So these are essentially overlapping, and carboplatin did not improve disease-free survival, nor did it improve overall survival for these women. So this is frustrating that we have conflicting data from two well-designed phase 3 trials. We struggle with how to interpret this and put this into context. Well, I think one important thing to remember is that these large trials were not statistically powered to show a difference in survival. They were there to show a primary endpoint of pathologic complete response, right? The degree of shrinkage at the time of surgery. And so there might be differences in survival there, but we just didn't have the power or the numbers to prove it. Another really interesting concept was presented this past summer, published by statistician Don Barry and Cliff Hudis, to show that in order to see a difference in survival, you need to have a really large difference in pathologic complete response in your clinical trials. So if you remember, both the GeparSixto and the CALGB studies had only about a 10 to 15% absolute difference in pathologic complete response. And with that relatively small amount, we may not see a significant difference in survival ever, that you really need bigger differences. And I think outside of just the statistical reasons that there might be discrepancy, another very practical matter may be the backbone chemotherapy that was used. So the German study used a different anthracycline at a different dose and schedule in combination with weekly paclitaxel. And if you remember, that regimen did not have cyclophosphamide. In contrast, the CALGB regimen was a very standard regimen used across North America of both doxorubicin, cyclophosphamide, and taxane. And it may be that that better backbone chemo really negated any small incremental advantage to adding in the platinum. And then finally, it might be that the kind of platinum that is used might matter. So carboplatin is better tolerated in some ways than cisplatin, but we just don't know if there are activity differences between those two drugs. So I think still a lot of unanswered questions. This is a picture from a publication now almost 2 summers ago from a doctor at the FDA showing this correlation between pathologic complete response and disease-free survival. And what you would like to see is if there was really good prediction, this should be a diagonal line. And rather, this looks like a pretty flat horizontal line, saying that there really is not a tight association between degree of pathologic complete response and predicting a survival advantage to adding in these drugs, and in this case, platinum. So I think that neoadjuvant platinums are by no means a standard of care. These data are conflicting, presented at San Antonio, and there's still uncertainty throughout the academic community about the role for platinum in early stage triple-negative breast cancer. The good news is there's a lot of work being done on selecting predictors of benefit. So BRCA mutation status is important in triple-negative breast cancer. Guidelines would suggest any woman under 60 who has a diagnosis of triple-negative breast cancer should get genetic testing to know their BRCA status. And then meanwhile, there are plenty of other biomarkers in development trying to identify problems with DNA repair pathways, even in the absence of a BRCA mutation. Lastly, I would say that if your goal of pre-op therapy is to shrink the tumor more to enable breast conservation, or perhaps to go from having an unresectable tumor to being able to achieve a mastectomy, then using a platinum is very reasonable in that situation. But with the data we have available from our latest meeting, I would not routinely recommend platinums in the adjuvant setting. We really have no data that survival is really compelling data that survival is improved in that setting. All right. So we're going to switch gears a little bit and talk about a new compound that has very encouraging results for metastatic triple-negative breast cancer. So IMU-132 is what's called an antibody-drug conjugate. So the antibody portion targets a protein called TROP2 that is present on the vast majority of triple-negative breast cancers. Now, this is not something that you would routinely get from your pathology reports. This is all investigational. But in this particular study, because of the high prevalence of TROP2 on triple-negative breast cancers, eligibility just included having triple-negative breast cancer. Now, that antibody is linked to a small amount of a compound called SN38, which is a metabolite of a chemotherapy drug called irinotecan. Irinotecan has much more use in colon cancer. Occasionally, it's used in breast cancer, but one of the most limiting side effects of its use when given intravenously is very bad diarrhea, and that's been quite a limiting factor for it. So this particular compound, IMU-132, has been studied in a large phase 1/phase 2 study involving multiple solid tumors, not just breast cancer. But within that trial, there were 60 patients who had metastatic triple-negative breast cancer. All of those women had to have had at least 2 prior chemotherapy regimens, and the median was 5. So this is a very pretreated patient population. And what was really remarkable to see, despite these women having growth after taxanes and anthracyclines and many of our strongest drugs in breast cancer, the response rate was about 31%, and the clinical benefit rate was almost 50%. Now that means a combination of both shrinkage and prolonged stable disease up to 6 months. And so this was highly encouraging data. The median progression-free survival was 6 months. And if you try to compare that to, say, first-line data for some of our chemotherapy drugs in triple-negative breast cancer, median PFS is only about 3 to 4 months in that setting. So this was very encouraging. And I think most compelling, not only is this active, but it's very well tolerated. When we look at serious diarrhea, which is the main side effect from irinotecan, there was really rare serious diarrhea with IMU-132, only about 3%. So very well tolerated. And based on these data presented in December, just a couple of weeks ago, the FDA gave IMU-132 what's called breakthrough designation for triple-negative breast cancer. And this is wonderful. This allows the potential for this drug to make it to market faster, based on the really compelling data that has been presented so far. So that phase 2 trial is fully accrued, but there is a chance that we'll find out over the next month or two that they may ask, the FDA may ask for an expansion, allowing more women with triple-negative breast cancer to come on to that phase 2 study. And a phase 3 trial is already designed and hopefully opening shortly that will be dedicated to women with triple-negative breast cancer. And if that recapitulates what we've seen in the phase 2 study, then my hope is that we'll see this drug move along much more quickly and be available to women with more advanced triple-negative breast cancer. So please do keep an ear out for that. Okay, so we're going to switch gears and talk about HER2-positive metastatic breast cancer. So HER2 is a protein that is on the surface of about 20–25% of all breast cancers, and that protein drives the growth of the tumors. It really is an important component of that breast cancer survival. And what we've come to see years ago now is if we target HER2 with an antibody that binds to the protein and you add that drug trastuzumab to chemotherapy, it significantly improved survival. Now, we have many drugs since the development of trastuzumab that work for metastatic HER2-positive breast cancer. You may have heard about pertuzumab, which is another antibody to the HER2 protein. And these drugs are used now primarily in the first-line setting. But unfortunately, even with these great drugs in first-line metastatic breast cancer, there are recurrences or ultimately growth of the tumor and resistance develops. So we've needed additional drugs in later lines of HER2-positive metastatic disease. And that's where TDM1 comes into play. TDM1 is essentially the trastuzumab antibody, this Y-shaped schematic shown here. And it is another antibody drug conjugate, not unlike IMU-132. So here, trastuzumab is going to find that HER2 protein and bind to the HER2 positive breast cancer cell. But attached to it by this linker, MCC, is a little bit of chemotherapy, DM1. And so this drug is called TDM1, and it's a way to bring the chemotherapy directly to the HER2 positive breast cancer cell. So what we've seen already from a published study called the Amelia trial is that TDM1 compared to the other available regimen of the time, capecitabine and lapatinib, was significantly better. It improved progression-free survival, and what's not shown here is that it's a very, very well-tolerated drug given once every 3 weeks intravenously. So these were exciting data, and at San Antonio, the results of a study called the Teresa trial were presented. So the Teresa trial took women who had HER2-positive metastatic breast cancer who had already received trastuzumab, taxane-based chemotherapy, and even lapatinib, and randomized these women to TDM1 as a single agent or treatment of physician's choice, which really goes up against just about anything we have that's available to treat women with HER2-positive metastatic disease. So quite a bold study design, but really going up against anything else out there that oncologists might have recommended for their patients. And here what they found was TDM1 not only improved progression-free survival, but significantly improved overall survival up against whatever drug you compared it to in HER2-positive breast cancer that had grown despite trastuzumab and lapatinib and taxanes. So this is, I think, consistent with what we've seen from the Amelia trial, but tells us that TDM1 is an excellent option following progression on trastuzumab. All right, switching gears now to talk about immunotherapy. So immunotherapy is, as you've heard already, I mentioned before, this is being explored across all solid tumors and even beyond solid tumors, with the idea being that instead of all these other treatments I've talked to you about that is directed at the tumor cell, right? It's chemotherapy trying to kill the cancer cell and has some off-target effects on our healthy cells. Here, immunotherapy is trying to unleash our body's natural immune system to recognize cancer as foreign and fight it off, much in the same way it would fight off a virus or another sort of infection. So the schematic here is showing the body's ability to keep the immune system in check, and that's what's shown on the left. The T cell is one component of our natural immune system. And when the T cell sees the tumor cell as something that doesn't belong, the T cell receptor binds to what's called the MHC receptor. And that starts to trigger a vigorous immune response to fight off the cancer. However, if our bodies had an unchecked immune system, we would see tremendous problems. And as anybody who has an autoimmune illness knows, autoimmune diseases can cause many problems, including liver, hepatitis, joint and arthritis problems, skin reactions, GI toxicities. So autoimmune disease is clearly a problem, and having an unchecked immune system would really be harmful. So our body has a natural check in place. When the immune system is turned on by the T cell receptor seeing the tumor cell, it also immediately puts the brakes on the immune system, and that's through an interaction of PD-1 and PD-L1. So that on one hand, the immune system is revved up. On the other hand, we gradually start applying the brakes so it doesn't get out of hand. Well, the way our new novel immunotherapies are working is to release the brakes a little bit. So we have anti-PD-1 antibodies, and we also have anti-PD-L1 antibodies, which are interfering with that interaction between the tumor cell and the T cell and our body's macrophages to loosen up the brakes, loosen up the controls, and let our immune system see the cancer as foreign and fight it more profoundly. So we have a couple of drugs that have been presented this past year in triple-negative breast cancer. Pembrolizumab is one, and I'm going to be tongue-tied with this, but atezolizumab is another. Now, these are PD-1 inhibitors, and they're antibodies breaking up that relationship between the T cell and the tumor cell, so unleashing the brakes. Both of these studies that reported out this past year were phase 1 trials, tiny studies looking at women with triple-negative breast cancer, and found that they actually saw responses about 20% of the time. And although that sounds like a small number, you need to remember in the context of phase 1 trials, where these are women who've likely received multiple prior lines of treatment, that seeing a 20% response in a non-chemo approach really would be encouraging. So there are many immunotherapy trials going on right now, many of these focused in triple-negative breast cancer. I've listed a few of these on this slide that are going on around the country. We don't know yet whether immunotherapy should be used just by itself as monotherapy, or if perhaps adding it to radiation or adding it to chemotherapy may help even more. One concept is that chemotherapy kills off some of the cancer cells, allows more proteins to be expressed as the cancer cells die off, and helps the immune system see that as foreign. So this is still a big research question about the optimal strategy, but lots of trials going on right now in triple-negative breast cancer. Well, 2 studies were reported at San Antonio looking at the idea of immunotherapy in hormonally driven breast cancer. This first study is the Javelin trial of avelumab in solid tumors. Now, these trial participants had breast cancer, but their tumors did not need to be tested for the presence of PD-L1. So it was really any patient with metastatic breast cancer could be eligible as long as they had previously received a taxane and anthracycline and less than 3 prior lines of therapy. And you could see about half of these patients had ER-positive breast cancer, about a third had triple-negative breast cancer, and then a small amount that were HER2 positive. When we look at the side effects, the column all the way to the right of grade 3 or greater, these would be significant. A grade 3 toxicity is one that really interferes with day-to-day function. So fortunately, there were not significant amounts of grade 3 toxicity, but you do see an impact on liver function. About 2% had increased in liver numbers, suggesting an autoimmune hepatitis. There were some joint issues, so less than 1% of sort of aches and pains in the muscles and joints. About 2% feeling significant fatigue from this. So not unlike a profound autoimmune illness, but thankfully small numbers there. When we looked at response, the column on the left is showing overall everybody with breast cancer. The column on the right is showing those patients with triple-negative breast cancer. And objective responses were relatively low, about 5% overall, or 8 to 9% if with triple-negative breast cancer. But what was encouraging was what they defined as a disease control rate. So not necessarily seeing great shrinkage of the tumor, but able to keep the tumor in check. Not growing and not spreading is also a success in treating metastatic breast cancer. And if you're able to do that with a treatment that helps you to feel well and be out living your life day to day, well, by using that benchmark, about a third of the patients on treatment were able to keep their disease in check while on this anti-PD-L1 antibody. The second study in immunotherapy that was presented was the KEYNOTE trial of Pembrolizumab in PD-L1 positive hormone-driven metastatic breast cancer. So this is slightly different from the other trial I just mentioned. Here, everybody who was screened for this trial had to have tumor-expressing PD-L1 protein. And now we know the more PD-L1 is present, the more likely those tumors are to be triple negative, and highly estrogen-driven tumors are less likely to have PD-L1 expression. This was a phase 1b trial, specifically accruing patients with hormone-driven metastatic breast cancer, and PD-L1 positivity was defined as at least 1% staining anywhere in either the tumor or the tissue around the tumor. And treatment was given as shown here, about every 2 weeks intravenously. So 20% of all those women screened with ER-positive breast cancer were PD-L1 positive. So as I said before, the more estrogen-driven the tumor, the less likely they are to have PD-L1 expression. So about 20% of those screened were candidates for the study. 25 patients were treated. About half of those had multiple prior lines of treatment. And when you look at what they call here a waterfall plot, having bars below 0, like these orange and this yellow one here, are showing objective response, shrinkage of the tumor, 80% shrinkage, 60% shrinkage. So that's nice to see that kind of response from a non-chemo regimen in folks that had multiple prior lines of treatment. You can see some of these bars are hovering around 0%, and those would be considered stable disease, right? Not significant growth, but not tremendous shrinkage either. The median follow-up was about 7 months on the study, so we still have more observation and time to monitor these patients, but there is a signal that for those patients with hormone-driven cancer, if they express PD-L1, there is some activity in ER-positive breast cancer, not just triple-negative breast cancer. And again, no surprise, the toxicities that are listed here, again, reflect that autoimmune flavor to them. Autoimmune liver issues, elevated liver numbers, some muscle weakness, joint-related issues, and in this case, 1 episode of nausea and 1 very serious episode of shock. Okay, so we have 2 more really exciting, potentially practice-changing trials that were presented. The first that I want to touch on is an Austrian study called ABCSG 18. Now, the background to this trial was that there have been multiple smaller studies over the years that have started to give a suggestion that using bone-directed therapies, bisphosphonates, could improve breast cancer-related outcome. And that was a remarkable observation, but many of these smaller studies had some either design flaws that didn't apply necessarily to our practice patterns and patient populations, or were conflicting, where one good design study said there was a benefit, and then the next one would say that there was not a benefit. So the ABCSG 18 trial was a large phase 3 randomized study conducted in Austria using a newer bone-directed therapy, denosumab. Denosumab is what's called a rank ligand inhibitor. Rather than being a pill or intravenous, it's a small injection right under the skin. And it has a role in treating osteoporosis, and it also has a role in treating metastatic breast cancer that has spread to the bone. We know that using an injection of denosumab under the skin on a monthly basis has significantly improved skeletal-related events when you have the presence of breast cancer in bone. So the Austrian trial checked to see if we use denosumab in early-stage hormonally driven breast cancer in postmenopausal women receiving an aromatase inhibitor, could we improve the risk of osteoporosis? Could we lower the chance of fracture? That was the primary goal. So women received a tiny dose of denosumab. Rather than monthly, they would get that twice a year, and they did that for 3 years. And that study reported out its primary endpoint at ASCO about 6 months ago, where they saw a 50% reduction in fractures in women receiving denosumab twice a year for 3 years if they were postmenopausal receiving an aromatase inhibitor. So that was really exciting data, and when that was presented with very minimal side effects associated with it, The advisory board for that study said we need to unblind the trial, and all those women that were getting placebo need to be aware of these results and have the opportunity to now cross over and get denosumab because there was a significant improvement in bone health. Well, the follow-up to that, which occurred about 6 to 8 months ago, was a secondary endpoint in looking at breast cancer-related outcomes. As I mentioned, there's been this controversy over the years about whether bisphosphonates improved breast cancer-related outcomes. Well, the denosumab trial wanted to take a look at the same thing. So here's the study design. This included postmenopausal women, early-stage hormone-driven breast cancer, receiving an aromatase inhibitor. These women, there were more than 3,000 women on the study, and we've now had several years of follow-up. And again, they received denosumab twice a year for 3 years. So I mentioned to you already the 50% improvement in fracture rate. But what was really exciting was seeing a difference in disease-free survival. So recall this was a secondary endpoint, and this slide that I'm showing you right now shows about a 20% improvement in breast cancer-related outcome by using denosumab. But this just missed statistical significance. If you see, the p-value is 0.051. Anything under 0.05 would have been considered positive. But I'll explain that you have to recall the study was sort of forced to report out early because the advisory committee said we need to unblind the trial and allow the people that were on the placebo arm to cross over. So when we redo this analysis, taking into account the crossover, you can see that, yes, there's still about that 20% improvement in breast cancer-related survival for the women who received denosumab, and now it meets that statistical significance, that cutoff of 0.05 or less. So this is really encouraging. It's telling us, again, that denosumab has now improved disease-free survival for women with hormone-positive breast cancer receiving this treatment in the early stage setting every 2 times a year for 3 years. Now, shortly after the ASCO presentation, there was a large meta-analysis. This is conducted every 5 years in Oxford, where all the early stage adjuvant trials in breast cancer are pooled, and certain particular clinical questions are asked of the data. And the thought is that the power is increased because of how many numbers of patients you have by pooling all these data. Well, the Oxford group looked at the use of bisphosphonates over the years with now almost 19,000 women on these trials. And they reported out that using a bisphosphonate significantly lowered the risk of recurrence from breast cancer. And here, this was irrespective of what kind of bisphosphonate was used. Some of them were oral, available in Europe. Some of these are intravenous, like zoledronic acid, which we use here in the United States. But there was a clear advantage to lowering the risk of recurrence for postmenopausal women. Well, so our denosumab data that was just presented at San Antonio is consistent with what was seen in this Oxford overview. And if you look at not just recurrence, but death related to breast cancer, there was a significant improvement for postmenopausal women seen as well. Here you could see 18% in the absence of a bisphosphonate, lowered to 14.7% in the presence of any kind of bisphosphonate. Again, this benefit only holds true for those women who are postmenopausal. They do not see this advantage in premenopausal women. But this is still meaningful, especially since there is literature for premenopausal women to now receive ovarian suppression with aromatase inhibitors, and that combination works a bit better than tamoxifen does. So if we're thinking from a sort of public health perspective of more premenopausal women being temporarily made postmenopausal by ovarian suppression, that would potentially make them eligible for bone remodeling agents as well. And what we're seeing, about a 20% improvement in breast cancer-related outcomes. So the Oxford meta-analysis, in short, showed about a 3% reduction in breast cancer-related mortality in postmenopausal women, and that relates to about an 18% difference when you talk about relative risk reduction. So the last trial I'd like to touch on is a study called CREATE-X, which is a new role for an old drug. Capecitabine is an oral chemotherapy that is used widely to treat metastatic breast cancer. And there was a large study conducted in Asia, in Japan and Korea, looking at using capecitabine in the post-op setting when women have received pre-op chemotherapy, went on to their surgery, and failed to have a complete response. So still had some residual disease there. And these women were then randomized to standard therapy, which would include radiation or endocrine therapy as appropriate, or receive 6 to 8 months of oral chemotherapy with capecitabine. The primary endpoint here was to look at that disease-free survival endpoint at 5 years out. And the eligibility criterion was very wide open. Any stage of early stage disease, HER2 negative, failed to achieve a pathologic complete response. And they could not have previously received capecitabine, which is very reasonable. When we look at the results in terms of patient characteristics, these were young women. About 60% of them had lymph node involvement. About 2/3 of them had hormone-driven cancer. When we look at what kind of pre-op therapy they received, these are women that almost all had anthracycline taxane-based chemotherapy. And one thing to point out, it's difficult to remain adherent to taking oral chemotherapy for 6 months straight. Capecitabine in the dose and schedule that was used in this trial can be hard to tolerate due to diarrhea and rash and very dry skin. So several patients, about 1/3, required dose reduction, and up to 1/4 just stopped prematurely because it was too hard to continue. But even with that dose reduction and terminating early, there was a disease-free survival and overall survival advantage by the addition of capecitabine for 6 months after pre-op chemotherapy for those with residual disease. And that's a significant improvement. This held true across all subsets of tumor, whether it was hormone-driven or triple negative. But I think it gives us hope for those women who have residual disease despite appropriate pre-op therapy. This study would suggest that there's a role for additional therapy and that might improve overall survival. And so I would encourage folks to talk to their doctors if this applies to them, and have that conversation with your oncologist to know that there is opportunity out there to do more in the face of lacking a pathologic complete response. And so I actually think I'm going to stop there to make sure I leave time for questions. The last slide that I will show is just to let you know there's a lot of exciting things going on in research, and particularly in trying to better understand the biology of breast cancers and personalize our treatment choices. I want to highlight one study that's going on at Memorial Sloan-Kettering right now that gets at this individualizing cancer care and chemotherapy choice. So we've collaborated with a lab at MIT that has created this teeny tiny device. As you can see here, this is how large it is relative to the writing on a penny. And that device has multiple pockets in it. So we're able to load into those pockets different kinds of chemotherapy or antibodies or targeted therapy. And what we've shown preclinically thus far is you can place that small device with multiple different drugs in it right into, say, a breast tumor, and leave it there for 24 hours, and then take out the device with a biopsy needle with a bit of the tumor surrounding it. And then section that up and look under the microscope and see around each particular drug what kind of cancer kill are you getting? How well is that drug working? With the hope being that you could then predict what treatments would work best for that particular cancer in that particular patient. It's been very difficult to have assays in the lab that truly predict what happens in a person. So there's a clinical trial going on right now in the pre-op setting for triple-negative breast cancer, where one of these devices can be placed in the tumor. It is taken out a day later, and then patients receive good standard conventional pre-op therapy and then go on to their surgery. And ultimately, we're looking to correlate what the device predicted and what ultimately happens at the time of surgery. And there's no reason to think that this should be limited to breast cancer or triple-negative breast cancer, but this could ideally be applied to any biology, breast cancer, and really to other solid tumors as well. So it's just a bit of where we're going with our current technologies. So I'm going to thank you all for your attention and leave a few minutes for questions while we're all together still. Thank you.
Thank you, Dr. Traina. That was tons of information that you gave us. So just quickly, just on the device that you were just talking about, someone's asking if that will be able to work on metastatic tumors that are in places other than the breast.
Well, that's what we would love, to take it to that point. This is very early in development, but there's no reason to think that the biology wouldn't hold up in metastatic disease as well. What would be a little bit trickier is it would require a biopsy. So if there's, say, a liver metastasis from breast cancer, the device would need to be placed in the tumor within the liver and then removed a day later. But that, if we could really personalize treatment, then that procedure might be worth it. Right now, it's being piloted purely in the neoadjuvant setting, as it's somewhat less invasive to do a breast biopsy than to do, say, a liver biopsy.
Mm-hmm. Okay, thank you. You talked about the IMU-132 trial and talked about the fact that the FDA has given it breakthrough designation for triple-negative breast cancer.
Right.
When will patients be able to, and how long do you think it'll come to the clinic?
That's a great question. So I think right now, breakthrough status is not the same as, say, an accelerated FDA approval where it can be accessed widely. But it is an important designation that can fast track that drug through the trial process, through the approval process, and hopefully get it to patients more quickly. So right now, the only way to get IMU-132 is through a clinical trial. The phase 2 study that is already open across the country is fully accrued for triple-negative breast cancer. However, I do anticipate that in the next 1 to 2 months, there may be more slots available. And the trial is currently accruing patients with hormone-driven breast cancer. So if you look at clinicaltrials.gov, you can search for IMU-132 and see if there's a site near you if you're looking for a trial, because it is actively recruiting for hormone-driven metastatic breast cancer. And then I would think that the triple-negative phase 2 trial may be expanding in the next 1 to 2 months, and then we anticipate a phase 3 study that will be going on around the country, probably within a closer time frame, 6 months or so.
Great. And if people call the SHARE helpline, we can also provide other sources for finding clinical trials that are a little easier to navigate than the government trial. So someone is asking about if there was anything about Palbo, about Ibrance, resistance to Ibrance.
Resistance to Ibrance. So not that I'm aware of that we yet know what the mechanisms are for palbociclib resistance, although it is an area of research and definitely exploration as more women are going to have access to the drug and potentially progression afterwards. Probably the latest that we know is the FDA just expanded the palbociclib label to allow for its use beyond first line. So that has been really encouraging. There was exciting data for fulvestrant with or without palbociclib in patients who had previously received endocrine therapy. and now the FDA has accepted that data and expanded the label. So it does not mean that if you've had palbociclib and progressed to stay on it, but rather if you never had the opportunity to get palbociclib before for hormonally driven breast cancer, there's now the opportunity in later lines.
Great, thank you. And if you could just clarify some of the trials that are available for HER2 negative, those with HER2 negative tumors.
Well,
Was
so
it the KEYNOTE?
I guess if you have a HER2 negative tumor, the next question is whether the tumor is estrogen receptor positive or if this is triple negative, because those are two very different avenues.
Right, so they're
Do you
talking
have
about ER and PR positive.
So ER positive, HER2 negative, metastatic breast cancer. I think that there are several areas to look at. Palbociclib is one of a class of medicines that are called CDK4/6 inhibitors. These are compounds that are important in cell cycling, in what controls a cancer cell from dividing and multiplying. And so while palbociclib is the first to market, there are several other CDK4/6 inhibitors in development that have phase 2 studies going on around the country. So that is one mechanism to look at for a targeted therapy that is added to endocrine therapy. Another class of drugs in ER positive, HER2 negative breast cancer would be the PI3 kinase inhibitors. So there are several PI3 kinase inhibitors in development and that are at the point of phase 3 trials now, where they're often placebo-controlled up against the standard of care, so endocrine therapy with or without the PI3 kinase inhibitor. These are oral agents, many of which do not require a biomarker positivity before coming on to the study, whereas some do. So I think that it's still a class of interest, and there are many trials going on around the country in that regard. So I would think those are two big areas of novel targeted therapies in ER-positive breast cancer. I would also say that it's worth talking to your doctors if you have metastatic breast cancer to seek out tumor genomic profiling. Because while this isn't a particular drug, I would say it's a global approach to how we're managing oncology these days, is looking at the mutations that might be driving a particular cancer at the individual level, and then looking for targeted therapies, if they're available, for those mutations that crop up. So I mentioned PI3 kinase is one of those mutations that can be found in tumor genomic profiling. There are also agents that target something called the fibroblast growth factor receptor. And we'll find these FGFR mutations in doing tumor genomic profiling, and then that can open the door to novel agents in a clinical trial that target that particular mutation. So I think just the concept of getting a tumor profile of somebody's ideally the most recent biopsy of a metastatic site will reflect the biology of what's going on now with someone's cancer, and then that opens the door to other novel agents that might apply.
Okay, great. And are tumor profiles the same? Someone mentioned that they had an impact gene sequencing done at MSKCC. So is that the same?
So not all, the methodology for tumor genomic profiling is not all the same. There are some commercial panels that are available out there. There are different numbers of genes tested, for example. Usually they're on the order of anywhere from just maybe 50 to upwards of 500. So it depends on the panel that's being done. I know the impact test that you refer to is one that we do here, and what's unique about that is not only it's upwards of about 450 to 500 genes that are tested in the tumor, but we also collect blood and check those same genes in normal blood. And ideally, we only want to report what's mutated in the tumor. So whatever is there in your normal cells is subtracted out from the tumor profile. And what ultimately is reported is only what's mutated in the tumor, because you want to make treatment choices of targeting just what's in the tumor, not what's there in all of your normal cells. So that's a slight difference in the impact profiling versus a lot of the commercial ones that are out there.
Okay. Right, I've got a
But I would
bunch.
mention that this is something that can change over time, that the tumor is trying to outgrow and survive despite our therapies. So new mutations can develop. So if tumor profiling was done on a biopsy from 3 years ago, and you've had multiple therapies since then, it is very reasonable to consider rebiopsying a new spot to see if other mutations have developed that can then help change treatment choices now.
Okay, thank you. So just to clarify, did you talk about the androgen receptor trial and what's the name of the trial?
I didn't. That is for patients with, well, there are a few different ones out there. So there's a study for AR positive triple negative breast cancer in metastatic disease, which is looking at bicalutamide plus palbociclib. That is ongoing and recruiting just at Sloan-Kettering right now. There is another study of enzalutamide, which is a potent AR antagonist. We already presented the data for that in AR-positive triple-negative breast cancer, showing significant activity and highly encouraging. So that's going to be moving forward in development in further clinical trials. But we do have an adjuvant trial opening up very shortly, within a matter of weeks, for early stage AR-positive triple-negative breast cancer following standard of care treatment to use enzalutamide almost as a prevention in the same way that tamoxifen would be used for ER-positive breast cancer. And then I guess another study in that setting of AR-positive triple-negative breast cancer is a trial with a compound called VT464. This agent both blocks the androgen receptor and lowers production of androgens and estrogens. So this trial is open to women with AR-positive triple-negative breast cancer or ER-positive metastatic breast cancer, regardless of the AR status, because it will lower production of estrogen. And there's also a cohort for men with breast cancer in that trial. So that's a simple pill-based therapy that is early in development, but open and accruing right now, and applies, as I said, to AR-positive triple-negative or ER-positive metastatic breast cancer.
Great. So thank you so much. We're out of time for today.
Oh,
Thank
of
you.
course.
Thank you for your time. You're so generous and so kind and so generous with your time with Share and other organizations as well. I know you're doing something later on this week about triple negative breast cancer.
Great. Yes, thank you. Thank you so much for your time. I really appreciate it.